Alrighty. I'm gonna take just a sec to look around and see who's here, who's attending. I don't need to call it out anymore. And then we'll go ahead and get started. Today we're going to finish our lecture. Hopefully, we might have a couple things we do on Friday, but finish our lecture about assessment. And then on Friday, we have an activity day. So you don't have any readings to do, but I'm gonna bring in assessments for y'all to do, and I'll show and tell some assessments, things like that, so. Alright. See who's over here. Thanks for your patience. I'm teaching 4 classes back to back on Monday, Wednesday, Friday. So I'm trying to get stuff done in between. And sometimes that is a little more challenging than I realize when I go to do it, so.
Your dress is really pretty.
Thank you, for anyone who, this is a very Midwestern thing, I have to tell you where I got it, and usually I have to tell you if I got it on sale. But it's from a website called Room Chic, and I really like their stuff, like their most expensive stuff is like $50, and most of the time you can get sales where it's 30 and under, so. Thank you, yeah, one of the things, this is weird, and I don't know how much of this you all need to know, but one of the things I've struggled with as someone who experienced 9/11 while I was in college is, what do you do on 9/11, right? I think they're like informally making it a holiday where it's like some sort of Patriots Day. So it's like, do you wear red, white, and blue? Do you wear black? Right? I don't know. And so I went with butterflies because I figured they're a symbol of hope. So that's sort of what I'm trying to roll with here.
I think it should be a holiday.
Yeah, I think so too. I'm hoping that it'll end up being like a Veterans Day or something in the future.
I don't think people should be in school on the day, but at the same time, I don't want to be alone.
Right,
That
right.
was a scary day.
It was really scary, y'all, and I know most of y'all in here were born after 2001, right? Yeah. But yeah, it was like no one knew what was happening. Social media was not really a thing, so you were getting really patchy things. They were evacuating buildings all over because they didn't know like what the next target was. Ironically, since I was at college in Gambier, Ohio, which is literally the middle of nowhere, I felt about as safe as I could be, right? That like nothing's gonna happen to me in Gambier, Ohio. We're not exactly like high volume target. But yeah, we had, our college was small, like Wesleyan, and we had a student whose dad was in the Twin Towers. And that like really affected everybody. And just the idea that like someone could take a commercial airliner and use it as a bomb, right? It's just like, I'm like getting like weird goosebumpy chills as I'm talking about it. It's really hard to wrap your head around if you're not a person who would ever do that, right? Which I'm assuming most of the people in this room are not. So that is certainly something that had a profound effect on me and sort of how I perceive the world around me. And I know for many people of our generation. And then just side note, to tie it to psychology, not that like trauma isn't tied to psychology. But one of the really interesting things that happens when something big like that happens is you form what's called a flashbulb memory. And it's like, what was happening to you when you found out about it? And mine is crystal clear. I'm like very sure of it. And then I went to Dr. Minnis's class last year to talk about memory. And he had them do a reading about how flashbulb memories are in fact horribly inaccurate. And I'm still convinced mine is accurate, even though I know that's not true, right? But I can clearly remember coming into my dorm room. Had been getting ready in the bathroom, and someone had, oh, this is gonna really date me, AOL instant messaged me and said plane hits Twin Towers. And my first thought was, what a horrible mistake. Because you don't think that's gonna happen on purpose, right? And I remember like I had to go to the health center because I was sick, and like watching the TV in the waiting room and seeing one of the towers fall. Oh, anyway, it was not a good day. And the ramifications and the fallout are not great, and I hope that we just continue to learn and grow from it and continue to come together as a nation. I think that's really important. Okie dokie, that being said, thank you all for letting me like having my 9/11 moment. It's kind of hard as people move further away from it, right? I'm gonna switch over to the captions on Google just because then they won't hide the slides. Oops. Hello. There we go. And today we're going to talk about actually one of my favorite assessment instruments. That's really nerdy to say, I know, but it's one of the ones I learned the most about. So we talked briefly about this first slide on the MMPI the other day. And again, some of this has changed dramatically. And one of the things I realized after I spoke on Monday is that I had not put in the slides about the most updated version of this assessment instrument. And so I went and I did that. So we'll have some information that if you printed the slides might not be in there. I do have the link on Blackboard to get to the most updated versions of the slides. But I just wanted to make sure you all have up-to-date science. In fact, I got the school to pay for me to take a like all-day seminar about the MMPI-3 when it came out so that I've had the up-to-date science to share with you all. This is what you get when you give people the MMPI, and it gives you general indications of how people did, and what it tells you a lot of information really quickly. So this first section would be your validity scales, and it's essentially, did they take the test in good faith? Are they trying to be honest? And in this case, yes, this person is within the range, everything looks okay. And then it gives you information about how they're doing. So this person is scoring really high on the old scale D, which is depression. Pretty good indication. That's probably their major clinical presenting problem, right? But they also have some elevations on hysteria, and I can never remember how to pronounce this old word. These have really old word names because they were come up with in the 40s. But basically both of these are like your psychological stress is manifesting as physical symptoms sometimes. They're also scoring high on the scale that basically measures anxiety, things along those lines. And also peaking a little bit on the schizophrenia scale, which you might be like, how many diagnoses does this person have? Typically when we see someone on the old MMPI peaking here, it doesn't mean they're psychotic. What it means is they're experiencing the distress and the detachment that people experience with schizophrenia. This last one also indicates that this person is introvert. So the MMPI was developed by a process called empirical keying. And so in order to do this process, you go through several steps, and it's very non-intuitive, but I think it's really interesting. So the first thing you do is you gather lots of items. And I'm sorry, this thing squeaks like crazy and I hate it. So apologies to your ears. And so you get lots of different sentences, questions from lots of different existing tests. Ironically, now a lot of times when people do empirical keying, they use a lot of items from the MMPI to do empirical keying, or you write your own maybe, and then you administer those items. So you give them to people. And in particular, when you're doing empirical keying, you want to give them to people who are already divided into groups. So in this case, they would give them, let's say, that depression scale. They would give them to a group of people who were already diagnosed with depression, and in particular, it was people at a mental hospital, I believe in Minneapolis, who were getting inpatient treatment for depression. And then you give it to a control group of people who are supposedly not depressed. And then you compare. You compare which items are the people endorsing. Remember, these are just true false. So which ones are the people who have depression all saying true to? And the people who don't have depression are all saying false to. Those become the items on your scale. And the test makers do not actually care what the items say. One of the original writers of the MMPI used to brag he had never read all the items. Weird flex, right? But that's what he rolled with. So for example, for a really long time, the first item of the MMPI was, I enjoy reading mechanics magazines. And this was something that went on, there used to be a masculinity, femininity scale. It was very traditional, let's put it that way. And then what you're gonna do is something called cross-validation. What this means is, okay, you take all those items that only the depressed people were endorsing, and you give them to somebody else who has depression and another group who doesn't have depression. And if it succeeds, if it can differentiate between the two groups, you're ready to use it, it's good to go. If not, you might need to go back and re-hone it, see which items you need to add or take away. There are some big problems, however, with the original sample when this was created. I mentioned that the control group was supposed to be non-pathological. However, the control group they had available to them that they used were the friends and family members visiting these patients in the hospital. What could be the problem with that? Yeah.
I can bring out other emotions because you're trying to like understand and sympathize with something well.
Exactly. They could be distressed because their loved one is in an inpatient hospital facility. What else do we know about disorders and families? Yeah.
Some disorders are genetic.
Exactly. So they weren't giving these people any kind of like clinical interview to be like, do you have depression? They were just assuming they didn't because they were hospitalized. So that makes it messy. The other big issue with the original sample is, as I mentioned, it was collected in Minnesota. It's also a Minnesota multi-basic personality inventory, right? What was the population of Minnesota like in, say, the 1940s? Did they look like some of y'all, or were they transparent like me? Yeah, very white, very Scandinavian. There were a lot of Scandinavian farmers, right? It was not representative in any way, shape, or form of the general US population. And so, unfortunately, they didn't do anything about that until they revised it in 1989. So for like 40 years, this thing got used with this horrible sample. That's problematic. They came up with a much better sample. They specifically wanted to find a representative sample. Like, let's make sure our sample actually has this percentage of people of this ethnicity, this percentage of people of this race. They actually called it the MMPI restandardization project. They added some items. They wanted to add some additional scales to give you some additional information. And then because the MMPI is often used for career screening for folks like police and firefighters, they took off items that were illegal to ask someone who was applying for a job. And also items that were in the language was offensive 40 years later. So then that was 1989. And then in 2008, we waited a long time. We got the MMPI 2RF. RF stands for restructured formats. And what had happened in the meantime between 1989 and 2008 is that a lot of research had been done. The MMPI is one of the most heavily researched personality assessments. You could do a lot of cool research with it, and they're always trying to make it better. And what they did when they looked at, and I'll go back so you can look at them, they looked at these clinical scales. And they noticed that often, like our example person, someone who was high on one of the clinical scales tended to be high on a lot of them. And they're like, why is that? Well, what they realized is because of the empirical team had all used the same initial battery of questions, a lot of these scales had the same items on them. And those items were measuring general distress. And so they pulled that out and they made a scale just for that. And they called that the demoralization scale, or RCD. They also made it shorter. It became 338 items. They made sure no items overlapped on scales at the same level of interpretation. This was based on research data with factor analysis, which we'll talk about in a few minutes, but they did not rekey this. They did not go back to the beginning. The MMPI 3 came out, I want to say, in 2021, might have been 22. And essentially, it just built off the RF and made it even better. So just a quick, okay, good. Here's where I have the slides. So 43 was the original MMPI, Hathaway and McKinley. I believe it was Hathaway who said he'd never read all the items. And as you can see, the norms represented people in Minnesota. And then you had the MMPI 2 that came out in '89. One of the co-authors of that was Graham, who was one of my professors. And they added new validity scales. Again, they cleaned it up. People were like, oh no, we've been using MMPI for 40 years. Why would we change it? But then when they started using it, they're like, oh no, this is better. The RF, as I mentioned, had a much more modern things applied to it. And then the MMPI 3, really, they got new norms. They really just thought about it comprehensively. They thought about what are we missing, right? What are we not measuring? So they added some scales. They have norms in Spanish as well as English now. And the nice thing is because it builds so much off the RF, those 10 plus years of research on the RF can be applied to the 3, which is beautiful. So we're not like chucking all that. The Ben Porak, who's the first author of both the RF and the 3, was also one of my professors in grad school. And in fact, when I took the MMPI 3 training, Yossi was my trainer for that. So I was like, oh, I feel like I'm back in grad school. So they added 72 items, but they got rid of 75 items. So they kept it around the same length. They want to keep it quicker. So total, it has 335 items. So 220 still exist from the original 1943 MMPI. 47 that had revised language from either the 2 or the 3. I don't know who that is, so I'm just gonna let it go to voicemail. Okay. And then there were 43 items retained that were created for the MMPI 2 back in 1989. They revised some of the wording, and then they have those 72 new items. One of the things the MMPI prides itself on is that they strive to keep the reading level that you need to take it very low. So it's at a 4th grade reading level, essentially. And that's because they want people to be able to take it and for clinicians to be able to get information, essentially regardless of how much information an adult has gotten. One thing I should note is what we're talking about now is all the adult version of the MMPI. There is an adolescent version, but there's no child version. Alrighty, so now there are 52 scales. We have expanded from 3 to 10 validity scales. We have 3 higher order scales now, and I'll explain those on a slide after this. There's your 8 restructured clinical scales. After they pulled out that demoralization, they created clean versions of the original clinical scales. And then you have specific problem scales now. You look at things like cognitive issues. Internalizing are things like depression, anxiety. Externalizing are things like substance abuse, acting out. And then interpersonal, how do you interact with other people? And then since the MMPI 2, one of the things that we've included is, as if I made it, that have been included are the Psi 5 scales. And these are scales that measure the big 5 personality traits. So it's got a nice pure measure of one of the leading ways of measuring personality. So I'm not going to go over all of these, you don't need to know this level of detail, but just to give you some examples of how these scales have evolved. So we now have measures of inconsistency. So for example, the VRIN is they embed items that are asking the exact same thing at different places in the test. Do you answer those questions the same way? Basically, are you paying attention? Then there's the TRIN, which is a measure of, do you just go through and go true, right? And then they introduced for the MPI-3 this combine. So it combines the VRIN and the TRIN and basically says, how much is this person paying attention? How much are they actually giving good effort to this test? We've still got that F for fake bad scale, but now we've got some different variations of that. So for example, the FP is even people with really severe psychopathology don't endorse these items. So if a person is endorsing a lot of those, they're either really severely distressed or there could be just lying, right? And you have to look at what would be the motivation for that. There's even one that measures whether you're exaggerating memory complaints. That's become a common civil suit issue, right? And then the L is now called uncommon virtues. That's that fake good scale. So these are those higher order scales that I was talking about. These are something they developed for the MMPI 2RF and refined for the 3. And so your first thing you see when you go to interpret it and you get the little like line graphs like we looked at initially is these 3 things. And these are overarching, how are they doing in 3 big categories of psychological adjustment. The first is emotional and internalizing. So mood, affect, anxiety. Then there's thought dysfunction. People who are experiencing psychosis or maybe even memory issues. And then you have behavioral or externalizing, so under controlled behaviors. These are those clean, restructured clinical scales. So you've got that demoralization one. And then they took all those original RC scales and they made them clean. And what's really interesting to me is when they do that, when they pull the demoralization out, some of these are not what you would expect. So the one that used to be the depression scale, the D scale, that was so high on our example, is now called low positive emotionality. So they're finding this is one of the biggest indicators of depression, is not just experiencing negative emotions, but like the inability to experience positive emotions. Huge, right? And different. And again, other things, now the schizophrenia scale, our person wouldn't peak on it because it's very clearly unusual perceptions or thoughts, right? And again, I'm not going to walk you through all of these, but this gives you some ideas about these. Then there are these specific problem scales that get at things you have genuine concerns about as a clinician. Are they having neurological complaints, right? For the first time, year of our Lord 2020, when this came out, they added one about eating behaviors, and all the eating disorder folks rejoiced because we've never been able to get solid info about eating from the MMPI. Previously, we'd have to supplement. And so they not only include specific eating behaviors, but also concerns about body shape and weight, which is the core psychopathology of all the eating disorders. Cognitive complaints, memory complaints. One of the first things you always look at in any version of the MMPI are the suicidal items and subscale. In fact, we would get like the same day in our mailboxes in our clinic, like these are the items on the suicidal scale your client endorsed. So that we call them right away if there were big ones. It takes a minute to score all this, as you can imagine. There is a computer program, but it still takes a minute. And so, basically, they have this scale, which helps you right away know, do I need to address this? Hopelessness, a big indication of things we need to look at. Self-doubt, low self-esteem, believe in efficacy, think that you are not going to be able to address your challenges. These are some of the other specific problem scales. So stress, worry, compulsivity, that one's also new. So getting more at the OCD side of things. Anxiety related experiences, anger proneness, and then behavior restricting. So when we talk about externalizing, we're talking about acting out. But what we find with people who internalize, to sort of aim everything inwards, is they like won't go out of their house, will restrict socialization. Externalizing include things like family problems, juvenile conduct problems. So this is a history of juvenile conduct. It's not current because they're supposed to be 18 or over to take the MMPI, right? Substance abuse, impulsivity, that one's new. Activation. So this is heightened excitation and energy level. This is like a measure of mania, a manic episode. Aggression, so physical aggression. And cynicism. So this is something that we used to pull from one of the other scales, and now it is its own thing. Interpersonal things, essentially grandiosity of self-importance. This is a new one. This gets at like narcissistic PD, but other issues as well. Dominance, disaffiliatives, so disliking being around people. This is not just like being anxious around people, but actively disliking being around people, right? Social avoidance. Shyness. So this is a little bit of that introversion, extroversion. But you get that a little more clearly here as well. So these are those big 5 traits. So aggressiveness, psychoticism, disconstraints, your under control behavior, negative emotionality or neuroticism, and then your introversion. And so from giving people this one 335 item, you get all this information. And again, you run it through some software. It's on like a Scantron that they fill out, and then you get a report that gives this all to you. And it's beautiful. Again, I'm super biased because these were my professors. Jack has now passed away, unfortunately. Yossi was about to retire. I don't know what the assessment world's going to do without him. But they were the guys who taught me all of this, and I was really fortunate. Again, I think I mentioned I didn't know what assessment was as an undergrad. I went to Kent State because there was an eating disorder researcher I wanted to work with, and I got a ton of assessment training from these guys, and they were lovely and helpful and supportive. I remember taking an MMPI to Jack and being like, okay, here's what the MMPI is saying. Am I missing something? Because this client is highly reactive. This was a client who had bulimia nervosa. She was abusing cocaine. And in our first actual therapy session, she started screaming at me because I was explaining to her the basic therapy for eating disorders, where you like monitor your food and then you look at what's happening and you change it. And she started screaming at me, "Mom, you want me to?" And I was like, did I miss something when I looked over the MMPI? And Jack was like, no, like this person did not have anything that would indicate that this might be an issue, right? When they came in. So it's just lovely to sit down with like an expert in the field and him to be so reassuring that, no, you didn't miss anything. You're okay. You're going to be a good clinician, right? There are other similar ones, including the personality inventory, assessment inventory, the PAI. This one is used quite a bit at the VA because it's integrated into their electronic charting system. So the client would take it on a computer and the scores immediately populate to their chart. So the PAI, instead of doing just true, false, you do false, slightly true, mainly true, or very true. I don't know where you differentiate between mainly and very, but that's me. It also has validity and clinical scales. It has scales for treatment consideration and interpersonal scales. It was developed using a method called the rational method, which is very different to empirical keying. So it was developed conceptually. Basically, they came up with a bunch of items. They gave them to clinical judges who work with people with those issues. And they said, which of these items look like things your clients would endorse? So it's about face validity, a lot of it, right? So some sample items: people are afraid of my temper. This goes on to a physical aggression subscale. People once close to me have let me down. Negative relationships, or I can talk my way out of just about anything. Egocentricity. This is what the PAI profile looks like, right? It doesn't look that dissimilar from the MMPI. The one thing I really liked about using the PAI is what's up here. They call this the skyline. These are normed scores for a specific population your person is in that you get to select. So like I was working in an outpatient clinical setting, I could set this to other people who are in an outpatient clinical setting. And then you would see, not only are they like above the 70 cutoff, but are they above what we normally see in people in this setting, right? This is unfortunately the only PAI profile. I mean, obviously these things are fairly guarded, right? And this person doesn't really like peak cut anything, which is fine, right? But a little less interesting. An older personality test developed by Patel. We'll talk about Patel a lot when we talk about trait theory. So he derived this 16 personality factor, or PF, from words and statements describing personality. It has 185 items, gives you 16, maybe not surprisingly, personality scales, personality factors. But then there's also 5 global personality scales, which again, maybe not surprisingly, match up to those big 5 traits that we'll talk about a lot throughout the semester. So an example item is, when I find myself in a boring situation, I usually tune out and daydream about other things. One of the things I find really interesting about the 16 PF, and I do have to say I've never given this, I have a copy, I'll bring it in so you all can look at it on Friday, is that the questions change in format. So some of them you answer true, false, and some of them are like multiple choice. It's really interesting, and then they're all just sort of added together somehow. But some people really like this, and there are shorter versions that have been made as well. This was developed using a technique called factor analysis, which was also used for the RF and the MMPI 3. This is a statistical method for finding order amidst chaos. So basically, rather than empirical keying or asking clinicians to come up with groups of items that'll be subscales, you put it into your statistics program and you say, magic computer, it's not really magic, science computer, right? Tell me which of these things are related. The terminology we use are which of these things hang together. And based on essentially how they correlate with each other, it tells you, you know, these 10 items are their own subscale, these 12 items are their own subscale. So it finds groups of items that are alike statistically. In order to do factor analysis, you typically give these items to a large number of people, and then you do this, and sometimes you just slice items. So you'll have items that just like don't load on any of your subscales, or like every other item is like, essentially, if we think of it as a correlation coefficient, like 0.7 correlation with everything else, and then you've got one that's like 0.2, probably going to chunk that one, right? So it allows you to use math, essentially, to determine which item should be on there. Again, this is an awful picture. but it's hard to find these things online for confidentiality reasons. But this is an example of what the profile would look like from a 16 PF. One of the things I liked about this one is that everything is dichotomous. So it's not like you score high on something. It's like you're scoring either towards one end or the other. Is recognizing that personality traits are on a continuum, right? And that's something that's really important to think about in psychology in general, but also throughout this course, is that a lot of people will just think you have a personality trait or you don't, right? Like, I'm just introverted. Well, you would score somewhere on the scale that would be towards introversion, right? It's not like you magically a yes, no. All right, so these were the big giant personality inventories. There are also shorter ones. And these are sometimes called self-report or just response inventories. These are questionnaires that the individual completes. If you've ever participated in particularly any of our online studies here, you probably have filled some of these out. They measure very specific things. They're often fairly short. So like the longest one I use is 70 items. The shortest one I use is 5, I think. Right, and so you think a lot about what we call participant load. You don't want participants to have to fill out too many. And these might measure things like mood or affect. They might measure things like behavioral, social skill. How do you do in a social situation? Or they can measure cognitive things like your thoughts or assumptions. The beautiful thing about these shorter inventories is these are often things that people can fill out not only at an initial assessment, but because they're so short throughout treatment. And you can actually use these to track people's symptoms throughout treatment. So one of the ones that's used for that is called the Beck Depression Inventory. So it's an affective self-report questionnaire, very well researched. And it asks people to essentially fill out multiple choice for each one, where they just choose the statement that best reflects their current symptoms. And so here are some of the examples. Suicidal ideas ranges from I don't have any thoughts of killing myself, all the way to I would kill myself if I had the chance. Work inhibition can go from I can work about as well as before to I can't get any work done at all. One of the things I really like about this questionnaire is that, yes, it hits all of like the DSM criteria for depression, but it also recognizes things that are not in the DSM, but that are affected by depression. And one of those is loss of libido. So I've not noticed any change in my interest in sex. I'm less interested in sex. I'm much less interested in sex, or I've lost interest in sex completely. And some therapists get squeamish and be like, well, I lied about sex, right? Well, for a lot of people, this is an important component of their relationships or just their lives in general, right? So if this is affected, other things in their lives are also affected. And so this, the Beck Depression Inventory is just 21 items. People can usually fill it out in 5 minutes or less. So you can even have them do it in the waiting room before they come in to see you for therapy, and then you look at it together. And what a lot of times what we would do is we would actually create a chart. And like I had a piece of paper, and we would just chart these things every week so they could see the decreases as well. You also know if they, and let's say going down on their depressions where they come in and it's shot way up, you need to focus on like, okay, what happened this week, right? Rather than maybe doing the nuances of whatever therapy you were engaged with. Alrighty, so one of the things that psychologists also do is collaborate with other professionals. So let's say we think this is not just in the mind, it's actually in the brain, right? Something is going on here. We would collaborate with neurologists and imaging technicians in order to get some neurological tests on that person. So these are designed to directly measure brain structure and activity. The one that's most commonly used in research or even in basic settings is the EEG, the electroencephalogram. This is what's happening to this little baby here. So each of those things on the cap is a little electrode, kind of connects to the brain. Gives you a readout of brain activity, but doesn't tell you anything about structure. But this is what the readout from that looks like. These are especially used if we're trying to diagnose something like epilepsy, for example, but can also give us other really interesting information. Neuroimaging is used more and more frequently now, not only diagnostically, but also in research. And it involves taking a picture of the brain in some ways. Sometimes it's stationary, like an X-ray, or it's a whole bunch of stationary things, like a bunch of X-rays put together. Sometimes it's more like taking a video of the brain. And so this can be done diagnostically or again for research while someone's doing a test. So have them do a memory test and see which parts of their brain are lighting up. There are several different types of neuroimaging techniques. And again, one thing I want to emphasize here is psychologists would not be the ones doing this, right? They would not even be the ones interpreting them for the chart, even though neuropsychologists do learn how to read these themselves. But they could use the information from this in a collaborative way with other providers to inform their treatment and assessment plans. So the computerized axial tomography or PACT or CT scan uses X-rays of the brain structure taken at different angles. So it's almost like slices. It's like if you did this physically, you would actually like take a person's brain and like cut it into slices. It does that with X-rays. It's sort of like choop, 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 right? And actually that's the noise the machine makes. And then anything that's really bright white or really dark is an indication of some sort of pathology. So everyone has these. These are called the vesicles. They are fluid-filled parts of our brain. They hold cerebrospinal fluid. They help with the general health of the brain, but also with things like our balance. But this right here, that's not normal. This is a bleed on the brain. And so this is something that would allow you to be able to say, oh, maybe we need to go in and do surgery to repair that, right? I follow eventing, which is a equestrian sport where people do dressage, the crazy cross-country jumping, and also show jumping. And one of the top US riders fell and got a traumatic brain injury a week ago, something like that. And they actually had to go in and like remove a portion of her skull because her brain was swollen so much. And that's a fairly common procedure. It's obviously not great to have it happen though. And so they're giving us recovery indications for that, but I'm sure they did some neuroimaging to indicate where in the skull is it going to be most helpful to do that. The MRI or magnetic resonance imaging uses the magnetic properties of certain atoms in the brain to create a detailed picture of the brain. This is higher resolution, but you can't do this if the person's unconscious or you otherwise get no medical history. Does anyone know why? It's a giant magnet. What might be problematic if you had it in your body? Yeah. Yeah. So if you have a pacemaker, screws in your knee, things like that, it won't rip it all the way out. I did used to say that because there was an episode of House where they did something with that. But I had someone who was an MRI tech who came up to me after one of my classes and was like, that's not right, Dr. Myers, something there. But it'll move it around, right? So imagine a pacemaker, move it around in your chest, right? Or screws, move it around in a knee you had surgically repaired. Not good, right? So they would opt to a CT test until they were sure you didn't have that metal in your body. As you can see, it's much higher resolution. You can get various colors, and it'll show you things like this is a tumor that that person had. The MRI is the one where some people do feel claustrophobic when they have it done. Some places do have open MRIs to try to mitigate that, or they'll do things like project an image or TV show or let you listen to music. Oh, and fun fact, it won the Nobel Prize for Medicine in 2003. The PET scan or PET scan stands for positron emission tomography. I'm never gonna have you guys like write these out on a test. You can just use the abbreviations. This is a computerized motion picture of chemical activity throughout the brain. It's very cool. It's very sci-fi. It actually uses antimatter in its reading. And you can look at things like brain activity. So this picture actually shows sort of a normal brain and activation, and then a cocaine user when they were using cocaine. So this is a very dated reference. You may or may not get it, but this is your brain. This is your brain on drugs. Question. So it's an old video, an old commercial where they had an egg, and they're like, "This is your brain," and then they fried it up. They're like, "This is your brain on drugs." It was a very scary PSA in the 80s and 90s. Again, today is Dr. Myers' old day, and that's fine. Another thing that we might do in the context of a larger assessment is a neuropsychological assessment. And this is where we're going to look at things like intelligence, cognition, perception, motor skills. So we can do standardized intelligence tests, like the Wechsler we talked about on Monday. We can look at visual memory, perception. This thing is called the Groove Pegboard, and it measures motor ability. There are pegs that are kind of like almost Mickey Mouse spear shape. You have to put them in a certain way, or they don't fit, and you're only allowed to use one hand. So good indication of motor skills. We also can do clinical observation. This is a way to more directly examine behavior. And so sometimes we'll do this in naturalistic environments. So this is most common with like a school psychologist or other behavioral health specialist who would watch a kid in the classroom. So my husband's best man works with kids on the spectrum, and he will do this. He will go into their classes in the back of the class and observe them to figure out the best treatment plan for them. Or to figure out like, why is the treatment plan not working? That type of thing. There can be other settings. Analog observation is observing them in an artificial setting. So what you have here, right, using that one-way mirror, they know they're being watched, right? And you would do this in your clinic or a lab. And then self-monitoring is probably the most common one we use, and that is where you have clients monitor themselves. So they fill out something like a food record that I mentioned earlier, monitor my food, or some sort of record of their thoughts or behaviors in between sessions. All right, so we have a couple minutes left, and I just wanted to do a little bit of a fun activity looking at psychological versus popular assessment. So psychological assessments are, as we've established, well validated. They have good reliability. They're based in research, hopefully, and theory, right? But popular assessments typically are not any of those things. They're just for fun, right? So for each of these, take a second to read it. How many of you think this is from a psychological test? How many of you think this is from a popular? Yeah, this was one that was in, I want to say like 17 or Teen magazine or something like that, right? One of those goofy ones that would be a BuzzFeed quiz today. I feel that I get a raw deal from life. Who thinks that is psychological? Yeah, this is an item from the RMPI. I think we all know, especially by how dated it is. The second one is popular. Geez, I need to replace that one. I don't even remember what a G-Shock is. How many days per week on average over the past 6 months have you eaten an unusually large amount of food and experienced a loss of control? If this is psychological? Yeah, this is from the eating disorder diagnostic scale. I had to remember which one of it was. And then we know that this is from the back because we just looked at this item. How about this one? Who was Martin Luther King Jr.? How many people think that's from popular? Yes. I think, okay, couple, yeah, how many people think that that might be from a psychological test? Yeah, a few, and then a lot of people don't know, which is fine. This is an item from the WISE, from the intelligence scale. There is a subscale that's sort of like factoids, and this is on there. How about this one? Which number should come next? And you've got a sequence of numbers. Who thinks this is from a popular test? How about a psychological test? Really interestingly, this is from a popular test that was masquerading as a psychological test. When I was in college and grad school, it was like really popular for people to have like IQ tests online and would ask stuff like this, but like this type of question is not on any standardized IQ test, but really interestingly. Oh, and we got a question in the chat. And yes, Lauren, that is fine. I will chat with you about that. All right, so come prepared to learn and fill out questionnaires and see stuff on Friday. And again, nothing to read for it. So a little bit more chill discussion day. And so Zoom, folks, if you're able to be in person, it'll be a much better experience for you.
Hi, Dr. Myers.
I'm
I
just
don't